Good morning, good afternoon. Thank you for the opportunity to present with you guys today. As we all know, healthcare facilities can become hazardous environments when adverse events and complications occur. With the overall incidence of adverse events now estimated at 9.2%, and approximately half of these are classified as preventable events. Checklists have been developed in medicine as well as other high-risk fields, such as the aviation field, to help to assign priorities to reduce avoidable errors, to minimize risk and improve safety for our patients. The World Health Organization developed a surgical safety checklist in 2008 as part of the Safe Surgery Saves Lives campaign. This program was piloted in 8 international sites and demonstrated significant reductions in postoperative morbidity and mortality. Other checklists have been shown to improve operating room communication and to reduce the number of communication failures. With a reduction in errors and improvement in communication, preoperative checklists not only can improve patient safety, but improve OR efficiency. The field of minimally invasive surgery is highly dependent on technology and can be vulnerable to problems secondary to equipment failure. These cases are especially at risk for errors, complications, and inefficiency. Due to this, members of the SAGES Quality, Safety, and Outcomes Committee and members of the AORN partnered to create a checklist specific to MIS procedures to help optimize case flow and minimize errors and frustration. This 45-item checklist is divided into items to be performed before the patient enters the room, after the patient enters the room, and after patient preparation and draping. There are circulating nurse duties, such as preoperative preference card review, as well as scrub person duties, such as ensuring that the appropriate trocars are pulled for the operation. The objective of this study was to evaluate the effectiveness of the SAGES AORN MIS surgery checklist in preventing case disruptions that can lead to delays, as well as to determine the ease of its use. The checklist was implemented across 4 institutions, including Carolinas Medical Center, the Ochsner Clinic, the Naval Hospital Camp in North Carolina, and the Inova Fairfax Medical Campus. The checklist was performed by the circulating nurse and the scrub person, and then a checklist assessment was performed by the operating surgeon with the operating team. The checklist was performed before or after the operation at the discretion of the primary surgeon. The checklist assessment included how frequently each of the 45 items was not performed, how often the checklist identified problems that ended up to cause delays, the estimated time delay, the items that were wasted due to non-adherence to the checklist, and the time taken to complete the checklist. Likert scales were then created to assess for things such as the frustration related to completing the checklist, with 1 indicating no frustration and 5 indicating extreme frustration. And then similar scales were then created for checklist usefulness and checklist ease of use. The checklist was performed in 114 basic and complex minimally invasive surgery procedures with an average case duration of 75 minutes. 24% of cases had items that were not performed and ended up causing a delay. When grouped together, 66 total number of issues were identified, and 39 of these were not performed and ended up to cause a delay. The approximate delay in the case due to these issues was approximately 4 minutes. The number of items wasted due to these issues was 17, and the average time to complete the checklist was 3.6 minutes. Surgeons scored the frustration during the case related to the checklist low at 1.3 and rated the checklist usefulness moderately at 2.6 and the checklist ease of use at 2.0. There were some checklist items that were more frequently missed than others, such as the preference card review in 14% of cases, but also the readiness of the carbon dioxide insufflator and the backup cylinder, the readiness of the Verus needle at the beginning of the case, and ensuring that the appropriate trocars and ports were available. There were also checklist items that were never missed, such as proper OR table orientation and functionality, the positioning of video monitors, securing the patient and padding pressure sites, and connecting the light source and the carbon dioxide source. We then compared the checklist assessments across institutions. And as you can see here, institution number 1 had significantly more items identified with the use of the checklist. Institution number 1 also took a longer time to complete the checklist. Institution number 3 rated the frustration during the case to the checklist higher than the other institutions. And then again, it was institution number 1 that found the checklist to be the most useful, but also the most difficult to use. We then compared checklist assessments when the checklist was performed before versus after the procedure. And the only significant difference here was that the time to complete the checklist was significantly longer when the checklist was performed before the operation. So in summary, the SAGES AORN MIS checklist identified problems in 24% of total cases that led to preventable delays. Overall, the checklist was easy to complete and not frustrating to perform, and surgeons found the checklist to be moderately useful. However, I think it's especially important to recognize that institution number 1 had significantly more checklist items identified than the other institutions, and in turn found the checklist to be the most useful among all the healthcare facilities. This facility also completed the checklist more often preoperatively and took a longer time to complete the checklist than the other participating facilities. This indicates that the more time preoperatively with careful review of the checklist could mean a more beneficial checklist. Facilities in which the operating room staff may be less experienced or less consistent may find particular benefit with use of the checklist, as well as operations that are performed at night or on an emergent basis, but this will need to be evaluated in future studies. With identification of the items most often omitted, this information could help to abbreviate the checklist in the future and make it more user-friendly. This could minimize the frustration and time to complete the checklist while maximizing its utility. There are limitations of the study to recognize, including the Hawthorne effect, which is an inherent improvement in a subject's performance secondary to knowledge that he or she is being observed. However, the checklist was performed in 53% of cases postoperatively, so hopefully this negates this effect. The checklists in which they were performed postoperatively do have a component of recall bias, however. In conclusion, the SAGES AORN checklist identified problems in 24% of total cases that led to delays. The checklist was easy to complete and not frustrating to complete, indicating that it could improve operative flow and enhance operating room efficiency and improve patient outcomes. These promising attributes of the SAGES AORN MIS checklist should be further explored in future larger scale studies. I would like to thank SAGES for allowing me to speak today, as well as all the participating surgeons for their support during this study. Thank you.